Welcome to the deep dive. Today, we're tackling a really crucial topic in hepatology, acute decompensated cirrhosis. Specifically, we'll be unpacking the updated admission care bundle from the BSG and BSL.
That's right. And it's so important because, as you know, the in-hospital mortality for decompensated cirrhosis, or DC, it's still worryingly high. We're talking 10 to 20%.
Exactly. And managing these patients is, well, it's incredibly complex. It's a multi-system disorder, isn't it?
Absolutely. You need a really rapid assessment of what's actually triggered the decompensation, plus a solid plan for managing all the potential complications, infections, ascites, AKI, GI bleeds, HE, the list goes on.
The original care bundle, the DCCB from 2014, was a big step towards standardizing that initial management.
It definitely was. And the evidence does show it helps improve care.
But here's the kicker. A recent national audit found that actual usage, completion of the bundle, was only around 11.4%, which is, well, surprisingly low.
It really is a striking disconnect, isn't it? We have this tool, we know it works, but it's just not being used consistently on the ground.
So that's what makes this updated bundle and the strategies to actually get it implemented so critical.
Precisely. So today, we'll dig into these updates, look at the new evidence that shaped them, and importantly, discuss how we can realistically boost its use across the country.
Because ultimately, this is all about improving patient outcomes and, frankly, reducing that unacceptable variation in care we're seeing.
Exactly. Better, more consistent care.
Okay, so let's start with the background. What really prompted this update? What's changed since 2014?
Well, there were several key drivers. Firstly, we've seen hospital admissions for DC climbing. And a big part of that, unfortunately, is alcohol-associated liver disease, ALD. Admissions for that specifically jumped by almost 60%.
Wow, nearly 60%. That's huge.
It is. And alongside that, perhaps even more worryingly, premature mortality from liver disease has actually increased by 20% since the start of the COVID-19 pandemic. That reversed a trend where things had been stabilizing somewhat.
So the problem is actually getting worse in some respects?
It seems so. And we also have to remember the context of that 2013 NCEPOD report, the one that found less than half, only 47% of patients with alcohol-related liver disease were receiving good care. That report was a major reason the first DCCB was created.
Right. That report really highlighted the need for improvement.
And then more recently, the 2022 Remeasuring the Units report basically confirmed that while there's been some progress, there's still significant unwarranted variation in care happening across different hospitals.
So the update wasn't just about the latest science, it was also about tackling these persistent system issues.
Exactly. It's about both incorporating new evidence and finding ways to make sure best practice actually happens consistently.
And tackling that needed a diverse team, I imagine.
Oh, absolutely. The working group was very multidisciplinary. We had hepatologists, gastroenterologists, acute medicine doctors, a critical care physician, a specialist liver nurse, pharmacist, a dietitian, all representing the BSG, BSL, and also the Society for Acute Medicine, or SAM.
That makes sense, getting all those perspectives in. How did they approach the actual update process, the methodology?
It was pretty rigorous. A comprehensive literature search using PubMed and Medline, covering everything up to May 2024, looking for new original research, updated guidelines, the lot.
And assessing the quality of that evidence.
Critically important, yes. We used the grade system, grading of recommendations, assessment, development, and evaluation to assess the evidence quality for each recommendation. So we know how strong the backing is for each point.
And I understand you also got input from clinicians actually using or trying to use the bundle.
Yes, that was crucial. We presented draft versions to a focus group of junior doctors. Their feedback on practicality, usability in a busy ward setting, that was invaluable for refining it.
Making it work in the real world.
Exactly. And then finally, we developed a specific strategy based on further literature review and discussion aimed at actually promoting the bundle's use. The whole thing was then endorsed by the BSG Liver Section, their Standards Committee, BASL, and SAM.
Okay, so a robust process behind it. Let's get into the nitty-gritty. How does this updated bundle define acute decompensated cirrhosis? Who is it for?
Right. So it's defined as that acute deterioration in liver function in someone we know has cirrhosis. Clinically, that usually means new or worsening jaundice, ascites, HE, maybe a GI bleed, AKI, or signs of systemic inflammation or sepsis. The key word is acute deterioration.
And once you identify that patient, the clock starts ticking on the bundle.
Absolutely. The guideline stresses completing the key elements within the first 6 hours of admission. It's about providing that structured initial management, especially in that first 24 hours when specialist input might not be immediately on hand.
Getting those critical first steps done quickly. And what are the common triggers for decompensation that clinicians should be looking for right away?
The bundle flanked the usual suspects. GI bleeding, both variceal and non-variceal.
Yeah.
Infection or sepsis, which is a huge one. Alcohol-associated hepatitis, sometimes acute portal vein thrombosis, drug-induced liver injury, ischemic injury, maybe from low blood pressure, and of course underlying HCC. Finding that precipitant is key to guiding management.
Okay. Let's walk through the updated recommendations themselves, maybe point out some key changes or important details, starting with the initial assessment.
Sure. So the initial assessment, it sounds basic, but it's fundamental. A full history, proper clinical exam, and the baseline investigations. This is about figuring out the cause and severity right at the start. The audit standard is 100% for this, logically.
Makes sense. And screening for infection, that's always high on the list.
Always. For infection screening, the recommendation is urinalysis and culture, a chest x-ray, and blood cultures for everyone admitted with DC. That's based on moderate evidence with a 90% audit standard. We know they're susceptible, and we need to find infections early.
What about ascites, specifically the diagnostic tap?
Right. If there's clinically detectable ascites, the recommendation is a diagnostic tap paracentesis as soon as possible to rule out SPP. Again, moderate evidence, 90% audit standard.
And a really important point here, isn't it, about coagulopathy?
Yes, absolutely crucial. The guideline makes it explicit. Standard lab coagulopathy, like a high INR, is not a reason to delay the tap. You don't need to correct it beforehand. Just get the sample.
Well, that's a common misconception cleared up. What should be sent from the tap?
Send the fluid for PMN count, that polymorph count, total white cells, microscopy and culture, and proteinalbumin. And really importantly, inoculate some fluid directly into blood culture bottles at the bedside. That definitely improves the yield for finding bacteria.
Good tip. Now, given the link with ALD you mentioned, what about the alcohol history?
It's a core part of the bundle. A detailed alcohol history, current and past intake in units, when the last drink was, any withdrawal symptoms. High-quality evidence supports this, 90% audit standard.
And link to that, thiamine.
Yes. For ALD patients still drinking, prompt parenteral thiamine and B vitamins, usually Pavernex or similar, is recommended. Again, high evidence, 90% standard. Essential to prevent things like Wernicke's.
And if someone is showing signs of withdrawal,
then alcohol withdrawal management needs assessment with a validated tool, like CIWAR or GMAWS. And based on that, start symptom-triggered benzodiazepines. High evidence, 90% standard. The guidelines specifically suggest considering reduced initial doses of benzos, like chlordiazepoxide or lorazepam, because of that altered liver metabolism.
right, careful dosing there. Okay, moving on to specific complications found early, SBP treatment.
If you diagnose spontaneous bacterial peritonitis, usually that PMN count of 250 or more, prompt broad-spectrum antibiotics are critical. Follow local policy, then adjust based on cultures. High evidence and a strict 100% audit standard for this one.
And the role of albumin in SBP.
Still strongly recommended. Intravenous albumin for SBP, 1.5 grams per kilo of 20% human albumin solution at diagnosis. This helps prevent hepatorenal syndrome. Moderate evidence supports this, 90% audit standard.
What about the initial approach to AKI? Acute kidney injury.
Okay, for AKI initial management, the first steps are crucial. Stop diuretics, stop any potentially nephrotoxic drugs immediately, and assess their volume status thoroughly. Moderate evidence, 90% audit standard.
And if they need fluid?
For fluid resuscitation in AKI, the recommendation is cautious crystalloid boluses, maybe 250 millicol at a time, with frequent reassessment of volume status. The goal is euvolemia and getting urine output over 0.5 millik/hour based on their dry weight. Moderate evidence, 90% audit standard here too.
And there's been a shift away from routine albumin for initial AKI resuscitation, right?
Yes, that's a key point.
Yeah.
Routine 5% HAS isn't generally recommended for initial AKI resuscitation anymore. However, European guidelines do mention considering 20% HAS, 1 KIJ day for 2 days, if the creatinine's over about 133 null bound, 1.5 milligl, or if the AKI seems linked to infection, so some nuances there.
Okay, let's switch to another emergency. Acute variceal bleeding. What's the first-line drug?
Acute variceal bleeding management terlipressin is first line, unless contraindicated. The dose is 2 milligram IV stat, then 1 to 2 milligram every 4 hours. Or just 1 milligram QDs if they weigh less than 50 kilos. High evidence, 80% audit standard.
And antibiotics are key for any GI bleed and cirrhosis.
Absolutely. Prophylactic antibiotics for GI bleeding recommended for all cirrhosis patients with GI bleeding, according to local protocol. High evidence, 90% standard. It reduces infections and improves survival. You might consider stopping them after successful endoscopy and stable child pew happens without infection.
What about blood transfusions?
The approach is a restrictive transfusion target. Aim for a hemoglobin of 70 to 80 GL as in stable patients with upper GI bleeding. High evidence shows this leads to better outcomes, lower rebleeding. 90% audit standard.
And managing hepatic encephalopathy in this initial phase.
For conscious patients with hepatic encephalopathy, oral lactulose is the recommendation. Moderate evidence, 90% audit standard.
Finally, VTE risk, thromboprophylaxis.
Yeah, it's complex because they can be prothrombotic despite abnormal clotting tests. So thromboprophylaxis with low molecular weight heparin, LMWH, is recommended for admitted DC patients unless they have active bleeding. The evidence quality is low, but it's still a 90% audit standard because VTE is a real risk.
Okay, that covers the core bundle elements. The paper then goes deeper into managing specific complications. Let's start with infections, given how common and dangerous they are.
Right. Infections are a massive issue. Patients with cirrhosis, especially with ALD, have impaired immune function, so they're highly susceptible. Infection is often the trigger for admission, and it worsens prognosis significantly, even in early-stage disease.
And they don't always present, typically.
Exactly. Fever, high white count, these might be absent, so you need a high index of suspicion. Procalcitonin isn't very helpful. It's often raised anyway.
What kind of bugs are we usually dealing with?
Mostly gram-negatives, but the big challenge now is multi-drug resistance. So broad-spectrum antibiotics guided by local resistance patterns are key initially, with rapid de-escalation once you have sensitivities.
What about fungal infections?
Less common, but very high mortality when they do occur. Routine antifungals aren't recommended, but you'd consider them in high-risk patients, ICU, prolonged steroids for alcoholic hepatitis, that kind of thing. 2 negative beta-D glucan assays can be helpful to safely stop empiric antifungals if you've started them.
And just to reiterate for us, BP?
PMN count of 250 or more in acidic fluid, prompt broad-spectrum antibiotics. And don't forget the IV albumin, 1.5 GL grams at diagnosis, maybe 1 GL at day 3 to reduce the risk of HRS. That albumin benefit hasn't really been shown consistently in other types of infection, though.
Okay. Let's move to acute kidney injury, API, another major complication.
Huge. Affects 20–30% of hospitalized patients with cirrhosis and really impacts outcomes badly. Prerenal causes, often dehydration or overdiuresis, are most common, then ATN, then hepatrenal syndrome, or HRS, and sometimes other intrinsic or postrenal causes.
Diagnosis is based on Aiken criteria.
Yes, using the Aiken criteria. Remember, their baseline creatinine is often low due to low muscle mass, so even small rises are significant. Staging helps quantify severity.
And identifying the cause is crucial, especially distinguishing HRS.
Absolutely. HRS-AKI has specific diagnostic criteria. Cirrhosis with estates, meeting AKI criteria, no response after 48 hours of stopping diuretics and giving albumin, no shock, no recent nephrotoxins, and no structural kidney disease on imaging or urinalysis. It carries a very poor prognosis if untreated.
So initial AKI management again.
Stop diuretics and nephrotoxins. Assess volume status carefully. Resuscitate with crystalloids cautiously, aiming for euvolemia and that urine output target of 0.5 millikilo GRR based on dry weight. Routine 5% albumin isn't recommended here.
But 20% albumin might have a role.
Potentially, yes. European guidelines suggest considering 1 kg day of 20% HAS for 2 days if creatinine is 1.5 milligl or AKI is linked to infection. If they don't respond or worsen, think about escalation to HDU-ICU. RRT is an option for selected patients.
And if it is confirmed HRS-AKI?
Then the treatment is vasoconstrictors plus albumin. Terlipressin is the main one. Usually start 0.5 milligram IV QDs, titrate up to max 2 milligram QDs based on creatinine response, plus IV albumin, typically 20–40 grams per day.
But terlipressin has risks.
It does. Respiratory issues, infection risk. The MHRA recently advised caution with high creatinine, 442 mLs, ACLF grade 3, or MELD 39, unless the benefit is clear. And you typically stop beta blockers if starting terlipressin for HRS. Sometimes a continuous infusion or lower albumin dose might be considered.
Okay. What about hyponatremia, another common electrolyte issue?
Very common in advanced liver disease. Associate with worse prognosis, HE, HRS. Usually it's hypervolemic hyponatremia, too much total body water, but effective circulating volume is low. Can be made worse by hypotonic fluids. Less often it's hypovolemic, maybe from overdiuresis.
So management depends on the cause.
Exactly. Assess fluid status carefully, review meds. For hypervolemic, it's usually fluid restriction, maybe 1 liter a day, unless they also have AKI. Withhold diuretics. For hypovolemic, give 0.9% saline cautiously.
And the key is slow correction.
Crucial. Aim to raise sodium by no more than 8 millimol in 24 hours. Too fast risks osmotic demyelination. Hypertonic saline is really only for life-threatening neurological issues, usually in ITU.
Right. Let's turn to gastrointestinal bleeding, a true emergency. Management principles.
Treat any upper GI bleed and cirrhosis as VASL until proven otherwise. Manage in HDU ICU. Airway protection is vital if there's massive bleeding or altered consciousness. Resuscitate to restore volume, guided by pulse and BP.
First-line drug.
Terlipressin, as we said. 2 milligram stat, then 2 milligram QDs. Reduces portal pressure. Be aware of risks, especially cardiac or vascular disease. Review the need for it at endoscopy. Consider stopping after hemostasis, especially in Child-Pugh A.
Alternatives if terlipressin contraindicated.
Octreotide. 50 millicitogram bolus, then 50 millicity-hour infusion.
And antibiotics.
Essential. Prophylactic antibiotics for all cirrhosis patients with GI bleed. Reduces infections, rebleeding, mortality. Follow local protocols. Consider stopping in stable Child-Pugh, post-hemostasis.
What about PPIs?
No proven benefit for variceal bleeding. Might increase SBPHE risk, so generally avoid before endoscopy unless you strongly suspect a non-variceal source like an ulcer.
Transfusion strategy.
Restrictive. Aim for HB70/80 GL in stable patients. Better outcomes. Don't routinely correct INR or platelets in stable patients, no benefit. Might increase portal pressure. For unstable patients, discuss with endoscopy hematology. Major hemorrhage protocol might be needed.
Tranexamic acid.
Not recommended. No mortality benefit shown. Potential VTE risk increased.
And endoscopy timing.
Within 24 hours after adequate resuscitation. No proven benefit of rushing within 6 hours versus 6-24 hours. Key predictors for needing urgent intervention are liver disease severity, MLOD, and hemodynamic instability. Consider prokinetics like erythromycin beforehand to improve visualization.
Okay. Moving on to hepatic encephalopathy, HE. Key management steps.
Identify and treat precipitants. That's number 1. Infection, electrolyte imbalance, GI bleed, constipation, sedatives, look for them. Serum ammonia can help, but isn't essential for diagnosis if clinically obvious. A normal level makes HE less likely if they're confused.
And management.
Grade 4 HE, needs ITU and airway protection. For conscious patients, oral lactulose is standard, aiming for 2-3 soft stools a day. Can give via NG or enema if consciousness is reduced. Rifaximin doesn't help in the acute setting in critical care, more for secondary prevention. Consider a CT head if the cause of confusion isn't clear.
The bundle also flags VTE risk and nutrition. Can you expand on those?
Yes, so VTE risk. Cirrhosis messes with hemostasis in complex ways, often increasing VTE risk despite high INR. While evidence for LMWH prophylaxis is low quality, EESL guidelines suggest considering it for patients with risk factors if there's no active bleeding. So the bundle recommends considering LMWH.
Nutrition.
Absolutely critical. Malnutrition is rife and worsens outcomes. Standard tools like BMI are unreliable due to fluid retention. Needs cirrhosis-specific tools if possible, like the Royal Free Hospital one, or anthropometry.
So assume everyone's at risk.
Pretty much. Consider all DC patients at risk. Refer to a dietitian ideally. Monitor intake. Use supplements. Consider enteral or parenteral feeds if needed. And watch electrolytes closely due to refeeding syndrome risk, especially with alcohol history. Correct deficits promptly.
Finally, the importance of ongoing review and planning for escalation.
Essential. Consultant review within 6-12 hours. Specialist gastro-HEPA review within 24-72 hours. Need a designated liver lead in each hospital. Early escalation planning is key if they're not improving after 6 hours, especially if they were previously, first presentation or transplant candidates, think HDU ICU. Discuss with seniors. Prognostic scores like SOFA can help predict ICU outcomes, and crucially, advanced care planning and early palliative care involvement for those where escalation is futile.
So we have this updated, comprehensive bundle, but going back to that implementation gap, the paper outlines strategies to improve usage.
Yes, because that gap is the major challenge. Why is usage so low? Probably a mix of things. Lack of education or recognition outside specialists, maybe not enough buy-in from ED or acute medicine, perceptions that it's too difficult, problems accessing things quickly, flunky electronic records.
It's a common problem with bundles, even well-known ones like sepsis.
It is. Simple reminders help a bit, but real change needs full institutional backing. Team buy-in, regular education, local champions driving it, performance feedback, and embedding it in electronic systems.
Like the success seen in Newcastle.
Exactly. They achieved over 90% usage with strong support and financial incentives. It shows it can be done, but it needs sustained effort.
So what are the suggested strategies? National level.
Nationally. Engage the Royal Colleges, SAM, BSG, BASL, pharmacy and nursing groups. get it into teaching, conferences, websites, training programs, work with CQC, NHS England, GIRFT, maybe short educational videos via QR codes, social media push, patient advocacy groups like the British Liver Trust,
And local
education for medical students, regular training for ED and acute medical teams, especially new starters, specialist nurses and local champions doing ad hoc teaching,
institutional level.
local liver champions in key areas like ED and AMU, regular audits with feedback, maybe incentives like best practice tariffs, and making it easy off-the-shelf electronic bundles for major EMRs, posters with QR codes, automated prompts in the electronic record. Make it the path of least resistance.
This has been a really thorough deep dive into the updated DCCB. It's clear we have a good tool, but the real work now is getting it used consistently.
Absolutely. That variability in care for DC patients is just not acceptable. This updated bundle, hopefully more user-friendly and backed by current evidence, is a step forward. But implementing it effectively using these strategies, that's the next big hurdle.
The hope being that better uptake leads to genuinely better care, better outcomes, and less of that variation across the board.
Precisely. It really makes you think, doesn't it? For these complex conditions like decompensated cirrhosis, how do we best bridge that gap between developing excellent evidence-based guidelines and actually ensuring they translate into consistent, high-quality patient care everywhere, every time? That's the ongoing challenge.